how do you think Letermovir might be used in the future, say at your institution?
Patients that come for transplant are very heterogeneous. They get different types of grafts, they develop different complications, and the risk of CMV varies among these groups and also during the time after transplant. So the very high risk groups clearly benefit from prevention. And certainly at our institution, we will provide Letermovir to high-risk groups such as T-cell depleted patients, mismatched cord transplants, patients that receive T-cell depleting agents. This trial, interestingly, the majority of the patients were standard risk. So about 70% of the patients in the trial were low risk. And the trial demonstrates that there was a substantial benefit for patients at low risk. So eventually, everybody would benefit from Letermovir, and we plan to use it for everybody at our institution. So even though we have in mind the high-risk patients, we recognize that it was useful for all patients.
And how is Letermovir given? Is it oral and intravenous, or?
There is an oral form and an intravenous form, and that's very important because it allows Letermovir to start very early after transplant. In the trial, the median time from transplant to starting Letermovir was 9 days, and 60% of patients in the trial started Letermovir before 2 weeks after transplant. And so the availability of the intravenous formulation allows patients with mucositis, patients that cannot tolerate oral medications, to start Letermovir early.
Now, I know that on that trial, patients could start Letermovir right after at day 0 or day 1. They could go out to day 22 or 23. What's your feeling about what the ideal date to start the Letermovir might be?
It's a very good question. The trial had a very large window for starting from day 0, from the day of the stem cell infusion, up to day 28, as long as the patients did not have CMV infection, so as long as their PCR was negative. Now, we know a little bit when CMV infection occurs. So in the T-cell depleted patients, usually CMV infections occurs early, and so there is a bigger need, a pressing need to start Letermovir early. Cord blood patients tend to reactivate later. So if we go by the trial of having just a negative PCR, perhaps you can say that you can start later in certain groups. However, a fact for all CMV prevention is that the earlier you start the prevention, the more effective it is. So I would say, given the population of the phase 3 trial, that I would say that it's important to start before the 2 weeks.
And to clarify one other point, and you mentioned this early on, that the patients included in this trial were those who were were CMV seropositive. In other words, CMV seronegative recipients were not eligible to go on this trial.
Correct.
So one other practical question that I have for you is there aren't that many drug interactions, but there's an odd interaction with cyclosporin, it appears, that perhaps you could describe in terms of dosing.
Yes, so patients that are on cyclosporin only require half the dose of Letermovir that is given to other patients. So the standard dose is 480 milligrams once a day, and patients on cyclosporin get 240 milligrams once a day due to the interaction of Letermovir with cyclosporin. Now, thankfully, the level of immunosuppressants is monitored routinely in every institution, so should not be a problem.